So before I get off the stage, or we get off the stage, for now, I'd like to introduce our next panel. We are thrilled to host a discussion between two Medicare program vets. We have Chiquita Brooks-LaSure, currently a senior fellow at the Century Foundation, and until January of this year, the administrator of the Centers for Medicare and Medicaid Services, CMS, and Sean Cavanaugh, former director of the Center for Medicare at CMS, current chief policy officer at Aledade, as well as his most important role, a member of our board of directors. Please join me in welcoming them.
Hello.
So, welcome everybody. I'm sure Chiquita has a million things to say about everything we just heard.
I do.
But before we do that...
Did well, Tricia. That was a lot. That was very impressive.
Sure, if you bring slides, you can... But before we do that, I wanted to talk a bit about the position you used to hold. Having worked at CMS, it's hard for me to convey the complexity and the enormity of the position of CMS Administrator. If you think of Medicare, Medicaid, and the exchanges, growing to close to 200 million people, well north of $1 trillion, but also each of them has a very different statutory, regulatory, and operational construct, and you're supposed to run it all. Having said that, I was looking in preparation for this back, reminding myself, I've known you for a long time, but reminding myself of your career. And it occurred, like, if you were going to sort of plan from earlier in life, like, I'm going to be CMS Administrator, what are the various boxes I should check on the way? Well, I might want to work at O&B at some point, probably need some Hill experience, probably need some CMS experience, probably need to know both the exchanges and Medicare and Medicaid. I mean, pretty extraordinary how, you know, I imagine the search from the Biden White House, like when they started going through this, it's like, oh, it's Chiquita. But the other thing, to go back on a more serious note, because this was very meaningful to a lot of my friends and colleagues at Aledade, was you're the first African American to have been administrator. Can you talk to us a little bit about what that historic first meant to you?
You know, I don't think it wasn't until I was nominated that and as time as being CMS Administrator, really understood how important it was to other people to see me in the role. And I remember when I was a kid, I read a lot of biographies, and I remember reading about so many people who were firsts, a lot of women and a lot of people of color. And I thought, I'll never be a first when I grow up because all the barriers will be, will be broken through. And then when I became a first, so many people found it meaningful. Some of our staff, and certainly when I would meet people across the country, I remember two stories in particular. One when I was doing an event with Senator Wyden, and someone came up to talk to me, and she just burst into tears and apologized and said, it's just incredible to see someone who looks like me in your role. And my last year as CMS Administrator at an event, someone came up to me and said, not only are you African American and woman, but you have a complicated name. And I have a complicated name. And she said, and you could have gone by your middle name. And it was so interesting because I do have a very complicated name. And there have been times in my life where I thought about my middle name by birth is Lynn, so I could have gone by Lynn, and then you all would be able to say my name easily. And I thought, here is a way that I am showing representation and being there for people by showing it's okay to, you can still achieve with not looking like everyone else. And I think that my own experiences, and not that my experiences match that of every other African American in this country by any stretches, but it was a powerful understanding that people want to be seen. They want want their leaders to have some perspective about their lives. And the more that we diversify who comes to the table, who speaks at the table, we get better results. And I really was very fortunate that we were able to have a more diverse team at CMS, and the Biden administration overall just continuing to bring additional voices to the decision-making table, because it's important.
Amen. Thank you for that. So before we pivot and think about a lot of the same things Tricia and David were talking about, let's look back. You just, still fairly recent that you concluded 4 years at CMS. Looking back, whether it's Medicare or Medicaid, any of the programs under your jurisdiction, what are you proudest of that you accomplished?
Yeah, I look back and I feel like we left it all on the field. I am really proud of our 4 years. And not that we did everything perfectly, but we tried and we accomplished some great things. I actually am so thrilled that you guys already talked about 2 M's. There's nothing that makes me happier than multiple M's in a conversation. So I have no favorites, as I say, so we'll talk about all of them. I'm so proud of how we strengthened the Medicaid program. It's not just that we hit record numbers of enrollment, but I think the rules that we set in motion, which I know are, under discussion, was really about raising the bar about what we expect out of the Medicaid program. And I think Medicaid has shifted. It is different than the program it was before the Affordable Care Act. Tricia talked about this a little bit, but I will just say, I don't think people appreciate how much Medicaid is really fundamental to our providers in this country. I did a lot of traveling and hearing from rural hospitals. There's a huge difference between the states that have expanded Medicaid and those that have not. And we really did up the bar in terms of what are the requirements for states, really trying to make sure that Medicaid is meaningful, not just a card in your pocket, but that you can actually go see the doctor. So super excited about what we were able to accomplish in the Medicaid program. We hit the lowest uninsured rate in our nation's history between the Medicaid program and the Affordable Care Act. So we're happy about all of that. And then on Medicare, drug negotiation for the first time we did it, and we did it well. I'm very proud of the job that the team did on negotiating and creating a new responsibility at just really rapidly, executing really well. And I think we would not have been able to pay for the changes to the drug benefit if we had not really taken on the task of trying to tackle drug costs. And this year, the out-of-pocket cap in Part D is $2,000. This is life-changing. It's really a big deal. I'm sure this audience knows because you focus on Medicare, but I don't know that people appreciate how many drugs the average senior takes in this country, and just how crippling these costs are for a lot of our families. And it's not just the Medicare beneficiaries themselves that are paying this cost, right? It's the sandwich generation that's trying to figure out, how do I help my mom and dad afford these drugs? How do I also make sure my kids get into college, and all of that? It is a multi-generational thing, and I'm really proud of us taking those important first steps of the first 10 drugs, and the law is still the law of the land, and hope that those continue. So those are my three highlights. We could go on and on, but those are the big.
I would ask you to touch on one other highlight, which was you and the whole administration were very intentional across your portfolio of programs of trying to make sure the programs worked for everybody, meaning that there were no missed populations, that, diversity, equity, and inclusion. Even in my program, which is about value-based care, there were elements of making sure we were targeting underserved areas, also providers who serve underserved areas. Do you want to mention something about your DEI initiatives?
Absolutely. I think that from not only for the people, but also for our healthcare system, it is crucial that we really make sure it works for everybody. And I think that there can sometimes be the perspective of government of just, well, I sort of say, throw it over the transom. Like, this is a good policy and people will take it up. And that's not how the world works. You have to go out of your way sometimes to engage and make sure that you are designing things so that everybody can benefit from them. And we really saw this, we all have seen this in various places, but COVID-19, it's hard to believe, but when we came in, the vaccines were just around the corner. They weren't even, it was just when certain populations could get the vaccines. The amount of time that the administration had to spend to make sure that the underserved got the vaccines and were getting treatment, it took a lot more effort because it takes more effort to reach some of the underserved, and you have to be intentional, again, not just for those people, but if you don't want the hospitals full of sick people, you have to go and make sure that the underserved are getting the treatments, getting the vaccines, getting the treatments. And so really in every conversation, every decision, really, I like to say kicking the tires and saying, okay, have we thought about, can everybody access what we're trying to do? Have we asked the questions? And particularly in the Innovation Center, really starting to look at the data, and absolutely credit to Liz Fowler, who said, let's look at our models and have we looked to see who's in them. I mean, we had a model for maternal health where everybody in it was white, right? Like, that's not where our crisis, not every single person, but mostly, I mean, a vast majority. And we have a crisis with our Black and brown moms, and really making sure we are answering those questions, asking ourselves those questions, and then saying, what do we do about it? And most people who are underserved are served by a certain set of providers. We also have to make sure we are bringing them along as we come up with these incredibly important innovations. We need to make sure they're part of that conversation.
So as you said, you spent 4 years, great team, as you, in your words, left it all on the field. There's an election, change in administration, and now we're in the situation that David and Tricia were describing. So let's reflect on that a little. What of the gains that you and the Biden administration made are you most worried about? And any other perspective on what's happening in Medicare, but as Tricia pointed out, the Medicaid implications for the dually eligible?
Well, I would say what I'm most worried about is really our coverage losses that potentially could come. And I would say coverage is necessary, not sufficient to a healthy world, right? But it is the starting place. And I think all of us can really identify with the frustration of the level of friction that we have in our world in general, but definitely in the healthcare system. And if we have time, we can talk at length about prior authorization and just some of those aggravations. But if you go through the eligibility process, it is really challenging. And I think I would say just some of the reconciliation bill is just like death by 1,000 cuts to Medicaid and the Affordable Care Act coverage. And, for so many people in our country, they've got a ton of things going on, right? And you should not be spending all of your time figuring out, did I fill out my paperwork properly, and being worried, because that drives so much of the bankruptcies in this country. We did the Affordable Care Act because a third of the bankruptcies during the Great Recession were the result of healthcare, and it's still a very high percentage today. So I'm really worried about just adding the red tape, even when you're trying to do it well, like we in many states during the unwinding of Medicaid, the COVID rules where people had to do eligibility determinations. We lost millions of people because of paperwork. And so the idea that we're forgetting these lessons, which are incredibly recent, and then talking about adding additional barriers is deeply, deeply concerning to me.
So just at a brief aside of how much the landscape can shift. 25 years ago, I lived in New York City, and I had a job working for the city, and my job was to help get rid of all the red tape so we could get all the kids, especially kids, on CHIP and Medicaid. And the mayor at the time was leading the initiative and railed against all the friction that you're describing. That mayor was Rudy Giuliani. This is the only time I will ever mention that. You mentioned prior auth, and we have a little bit of time, so let's go there. The program, Medicare specifically, as Tricia's data showed, is increasingly becoming a managed care program. And yet at the same time, I think, almost on a bipartisan basis now, people are chafing under how prior authorization is actually operationalized. You guys took some actions to try to provide more transparency, expediency, and so forth. What were you seeing, and what do you think is going to happen going forward?
Well, I would say that prior authorization is bigger than Medicare. It is an issue in all of the in the commercial market and some of the other payers. But when I would talk to providers, they felt by far that the most friction that they were experiencing was in Medicare Advantage. And Tricia touched on this, and I will amplify. Providers are so angry about prior auth. I did so many conversations, and one that really sticks in my mind was at a cancer center, and just they were showing me a chart. Nobody is excited about cancer treatment, right? They're not looking for the shiny new thing. And they walked me through the steps that it took to get somebody on their cancer treatment. The oncologist talked about how 50% of their time was spent on this. We do not want our oncologists spending 50% of their time going through prior authorization. And just like frustration over how much the back and forth and why are you rejecting the claims. I think that that's why it's a bipartisan issue, because people are really frustrated. And I personally am very agnostic about whether Medicare beneficiaries want to choose Medicare Advantage or traditional Medicare. Just think there should be an option for both. And there are things that MA plans provide that are good things that honestly I would say need to be in traditional Medicare. And we tried to do those through the Innovation Center, but the Innovation Center still has a lot of requirements around it about saving money and budget neutrality. And some of those things, again, I think need to be part of the core benefit. And MA plans often can provide those things. And so people are attracted to those plans. But we can't have it where you can't see your doctor. And too many times I would hear about situations where doctors were telling people, oh, you're in MA and now you have cancer. You got to get out of it. And you want to be in traditional Medicare. And as you all know well, switching between the programs sometimes is not easy. You don't want to switch when you're sick. And so I think that back to prior auth, I think this is something, again, that's larger than the Medicare program that needs to be tackled. But certainly with in MA, we have got to make sure we are preserving the core of the Medicare program, which is if you are older, you need to be able to see providers to treat the conditions that you have. And we need to, for the sake of the beneficiaries and for the sake of our healthcare system, make sure that our prior authorization has a common sense element to it, that it's really keeping waste, which there is, it's not that providers are perfect. Sometimes there is a place for prior authorization, but it can't be so burdensome that we lose our providers in our healthcare system, or that it's really interfering with care.
We only have a couple minutes left, so I'm going to talk fast.
Okay.
What's your quick take on an issue Tricia and David touched on briefly? There's been a lot of reorganization, a lot of downsizing of staff, both targeted and untargeted. As the former operator of the agency, or what do you think of what you've seen? Any thoughts of what the implications for both policymaking, but also the operations of the programs going forward?
Well, every administration has a right to make changes and adjustments, and that's the joy of being in control. That you do have choices. And I would just say that they need to be done really thoughtfully. And I am deeply concerned, I'm probably more concerned about some of my sister agencies, who obviously CMS works very closely with, but the changes at FDA, CDC, NIH, like, they are deeply concerning from a, what is our cancer treatment going to look like on the long term? Like, some of these changes are just really going to be devastating to our healthcare system. Around Medicare, specifically, some of the staff that were let go at CMS are the people who are the most responsive to members of Congress or to issues for Medicare beneficiaries or providers in our regions. That's where a lot of that work is done. The first round of losses at CMS were really very personally distressing to me. One of my now colleagues at the Century Foundation, Emma, was in that first round. That was some of our best and brightest. We had spent a lot of time getting those people in because CMS had been under a hiring freeze for 2/3 of our staff. We had worked very hard to bring in another round. And I think what was just so distressing is that it wasn't based on performance. It really was, you're temporary, and it was easy. And so I just feel really strongly that, again, an administration has a right to make changes, but they need to be done incredibly thoughtfully. And just because you don't have Medicare or Medicaid in the title of your job doesn't mean that you don't work on those programs, because so much of the work is interdependent. ACL's changes have huge implications, and CMS is now absorbing a lot of other programs, and there's nothing inherently wrong with that, but CMS already has had a flatlined budget for a lot of the core Medicaid and Medicare work, and then so to be adding additional responsibilities without changing the budget, how are we expecting that the agency is going to do the work that it needs to do for the people that are served by its programs?
And in conclusion, you mentioned you're at the Century Foundation now.
Oh, yes.
With a couple other all-stars. What are you all working on?
Well, I think one of the biggest things we want to do is just continue to be a voice and speak to the moment of what's happening and really reminding people what the stakes are. We met yesterday to just talk about all of the provisions. We all focus on health, listening to some of my colleagues about what some of these other committees do that I am not really, it was pretty shocking just to really look at across our economy, just some of these pieces. So we will continue to do our work of trying to highlight what's happening and what this would mean to the American people.
I'll conclude with one more anecdote about the job that you so capably fulfilled.
Yeah.
A while back, I was the deputy director at the Innovation Center under my friend Rick Gilfillan, and I don't think Rick would mind me telling this story. And he had a meeting coming up with the administrator, a one-on-one. And so he said, we got to sit down. I got to bring to her, and this was Marilyn Tavener at the time, like, I've got 15 unsolvable problems. I can't bring 15 to her. Let's get it down to 10. So we spent all the time. We got it down to 10. And then I sent him off to the administrator's office. And then he comes back in a couple hours. I was like, how did it go? He's like, well, I was in line with Cindy Mann from Medicaid, and she had 10 unsolvable problems. And John Blum had his 10 unsolvable Medicare problems. And he's like, thank God I'm not administrator. But thank you for being administrator.
Thank you.
We're done, and we'll turn it back to the CMA.